Great. Good morning, everyone, and I'm happy to kick off this session. So I have no disclosures. Perhaps my only disclosure is that I am a cardiac surgeon, and so almost everything I'm going to say this morning is going to be about the use of VA ECMO in patients with acute cardiac failure. So I thought it's hard to encapsulate all of the complexities of decision-making around ECMO in the next 8 to 10 minutes. But I thought I'd start with a case as a jumping-off point to sort of talking about some of the nuances in how one might manage these patients. So this is a case from our center from about 5 years ago. It's a story that's probably very familiar to many of you. 14-year-old transferred in from an outside institution with several days of non-specific chest pain, some malaise. Was seen at the outside institution. His EKG and echo were concerning, so he was sent in to us. On arrival, he looked pretty ill. He was tachypnic, tachycardic. There was a bedside echo performed, which looked worse than the initial referral echo. He had severe biventricular dysfunction. He had a chest X-ray admission, which clearly showed the beginnings of significant pulmonary edema. He was intubated, and promptly with intubation, his hemodynamics fell apart, and he was cannulated for ECMO. He was 14. He was about 50 kilos, and so he was cannulated sort of emergently for femoral arterial and venous ECMO. This was his echo. You can see severe LV dysfunction, sort of the typical smoke in the LV. This was his chest X-ray immediately after intubation, just before he was urgently cannulated for ECMO, so severe pulmonary edema, all consistent with severe LV dysfunction. So following ECMO, as is the practice in our center, he immediately was transported down to the cath lab, where he underwent an atrial septostomy and a myocardial biopsy. His story was not great, but somewhat consistent with the potential etiology of myocarditis. He did well. The biopsy did come back a couple of days later. He had fulminant myocarditis, and on day 6, he had this echocardiogram, still with a distended LV, the Strate septostomy, still smoking the left ventricle. But what was most concerning to the ICU team was the finding on the echo of what looked like clot, swirling blood in his aortic root. His aortic valve was not opening, and it looked like he was layering clot in his aortic root. So based on this, we decided the next day to take him to the operating room, and that our peripheral ECMO cannulation, which had worked well, it works well in many of our myocarditis patients, clearly had not served this patient well. So we converted him to central ECMO with an LV vent, closed his atrial septum, explored his aortic root. He did, in fact, have some clot in there that was evacuated. His course, again, typical for central cannulation, many washouts for bleeding and circuit interventions, and ultimately he did not recover, had an LVAD placed on day 13, and then was transplanted. So I review this case to really make the case that decisions about ECMO cannulation in our patients, it's really there's a spectrum of ways that one can do it, and it's a complex matrix and requires some level of pragmatism, and one cannot be dogmatic in terms of how we manage ECMO and what the cannulation strategies are. So particularly in our pediatric patients, the factors to consider, the factors sort of that tie you to a particular strategy are the following. The size of the patient, obviously. So in infants, really either you do peripheral cervical ECMO cannulation or central cannulation. And in the older patients, femoral cannulation or central cannulation or potentially axillary cannulation is an option. Indications for support also dictate what kind of strategy you might deploy in your patients. Is it post-cardiotomy support? Obviously, the best option there is central cannulation. ECPR, in the infants, again, cervical cannulation. In older patients, both cervical and femoral cannulation is an option. And then if it's an urgent but not ECPR cannulation, again, what's the best option? Percutaneous or open, femoral, or some other type of cannulation strategy. Having a sense about what you think the etiology is and what the duration of the ECMO run, I think should play some role into what strategy you decide to choose if time allows. What's the cardiac anatomy? Is this a single ventricle, a two ventricle patient? That will also dictate what kind of strategy you might use. If it's a cardiac patient who has been to the cath lab many times, it's critical to know if they have any occlusions. There's no point going for a femoral cannulation in a patient in whom the femoral vessels are known to be occluded. So that's a critical piece of information that the team and the surgeon needs to be aware of. And then what's your strategy for promoting ventricular recovery, but more importantly, decreasing ventricular distension? What's your vent strategy? And how will that interact with your initial ECMO cannulation strategy? And then last but not least, as I mentioned earlier, is the question of open versus percutaneous approach in some patients. So in general, this is how I think about the size of the patient and its impact on ECMO cannulation. Any child under 20 kilos, I think, should have cervical cannulation or central cannulation for most indications. Over 20 kilos, I will start to consider femoral cannulation as an option, and we'll talk about some of the strategies, the techniques that you might utilize to avoid vascular complications in these smaller patients. And then any patient that presents acutely or emergently that's over 30 kilos in our institution, femoral cannulation is the choice of cannulation or peripheral cannulation, unless there's a contraindication to that. And then obviously for post-cardiotomy support, again, central cannulation will be the best option. In terms of cervical cannulation, just again, this is an audience that understands cervical cannulation and its nuances, but to say that the things that I think are important is to consider the size of the cannulas that you can get into a particular child and what's the goal of your ECMO strategy. Are you going to be able to have adequate venous drainage with a single cervical venous cannula? Are you going to be limited by anatomy? Is this a Glenn or a Fontan patient or some variation of a single ventricle, or perhaps a patient that's already had an ECMO and therefore doesn't have particularly large neck vessels? These are all things that I think should play into your decision about whether you might go for cervical cannulations. Once cannulated through the neck, it is important to confirm a position of the cannulas, and this needs to be sort of part of the protocol, needs to be done both by chest x-ray and frankly by echocardiogram, because I think we have all seen patients whom the arterial cannula was down the aortic root and causing trouble there. In terms of femoral cannulation, as I mentioned, the size of the vessels and their patency needs to be known. And I think it's really important to consider the technique for cannulation and also how you plan to decannulate and what your plan is for repairing those vessels at the time of decannulation. So as I'm sure you all do, we have a chart on our ECMO circuits or ECMO cannula cards that sort of give you a guideline for what size cannulas you want for a particular size patient. We tend to generally want to follow this, particularly for peripheral cannulation. I personally believe that whenever possible, if at all possible, to avoid percutaneous cannulation, I would say that most of the peripheral vascular complications that I've had to deal with after ECMO have almost always come in the context of percutaneous cannulation. So I really dislike that approach, but I recognize that particularly for a patient in the cath lab, that may seem the most expeditious way to get a patient on. But again, surgical cut down is preferable. It really facilitates better vascular preservation. The other thing I think is important to recognize that if you've done enough of these femoral cannulation, it's obvious that vessel size does not always correlate with patient size, and so one has to be prepared to change course with cannulation strategy if the femoral vessels are not of the size you anticipated. What you don't want to do is undersize either the arterial or the venous cannula you place in a patient. And if you do need to cannulate, then certainly a strategy is to try and put a bigger cannula in. I generally believe that you should always place both venous and arterial cannula on the same femoral side, and that it's critical to place retrograde perfusion cannula in these patients. This is what a schematic of that might look like. So this is a femoral arterial cannula, and a retrograde cannula plays down the superficial femoral artery. These cannulas, these retrograde cannulas, don't have to be particularly large. We often use a small 6 or 8 Biomedicus cannula, but certainly people have described this, which is just a small angiocath in the posterior tibial, and it's amazing how little flow you actually need to keep a leg viable. And then a technique, if time allows, that I think it's really worthwhile to consider is to actually put a graft on the vessel. Then it obviates the need for a retrograde cannula, and it's a great way to perform a cannulation. Keys to femoral and effective peripheral ECMO is to obviously try to not only optimize unloading of the heart and prevent pulmonary edema, like as shown in these chest X-rays, but to make sure the cannulas are well positioned, and this needs to be confirmed either by chest X-ray or echo, or both. There needs to be a really solid plan for how you plan to decompress the heart, regardless of ventricular ejection, and I'll get to that in a second. We prefer at our institution to do atrial septostomy, but I recognize that you can put a pigtail catheter and do active decompression of the left atrium as well. And certainly I think nowadays any adolescent or teen of appropriate size, one should consider using an impeller device to unload the left ventricle, and there's a talk later in this session about that. But LV venting is critical. I think that our modus operandi is that you always assume there's significant left atrial hypertension. The degree of ejection or the findings of echocardiogram of no left atrial distension are not surrogates for the fact that there is no left atrial hypertension. And so this is something that we often struggle with when patients are referred to us, where they insist that the patient has no left atrial hypertension because they're ejecting. That is not true. So we routinely, regardless of ejection, will send a patient to the lab for a septostomy. But again, as I said, the vent strategies are patient-dependent. You could either do a percutaneous vent, atrial septostomy. You could do a direct LV vent as depicted in this picture. A small anterior thoracotomy gives you gate access to the LV apex, and you can, through a purse string, put a vent directly into the left ventricle, and obviously there is the impeller. But peripheral cannulation, as you saw in the patient that I showed you earlier, has some real limitations. So one of them, obviously, is inadequate decompression. Despite all of these vent strategies, there's still a subset of patients in whom you're unable to unload their heart adequately. And in this particular patient that I depicted at the beginning of the talk, developed significant clots in the aortic root. And so I think that that's a real concern, and when that happens, I think one has to change course. Another potential complication of femoral cannulation, I'm sure many of you have seen this, is when there's significant lung concomitant lung disease, and therefore the gas exchange in the lungs is really impaired, and the left ventricle ejects highly deoxygenated blood into the upper part of the body and potentially into the brain. And this is a phenomena that is seen in patients, again, who have significant lung disease that does not seem to parallel the recovery of their ventricular function. And this diagnosis can often only be made by if you have an arterial line or a pulse oximeter on the right hand. When this situation happens, obviously the concern is that the brain is seeing really the coroners are seeing highly deoxygenated blood. And when this happens, really the only way to intervene is to change cannulation strategy and go from peripheral cannulation to central cannulation. There is an option for adding an upper body venous or cannula for return. This could either be put down the venous system, so down the IGA or the right subclavian vein, so an arterial cannula, which converts this to VAV, so it's sort of a combination, a hybrid of VA, veno-arterial, and veno-venous ECMO to improve gas exchange, and alternatively, one can also place an arterial cannula down the carotid to make sure the upper part of the body has oxygenated blood. I won't spend much time talking about post-cardiotomy support. Suffice to say that it's central cannulation. In our center, our general rule of thumb is any patient who's post-cardiac surgery, who's had surgery within the last 2 weeks, even in ECPR situations, will have central cannulation and emergent reopening of the chest. If they are beyond 2 weeks, then we will have a real bedside conversation about whether we might go to peripheral cannulation, and that's primarily because within 2 weeks, it's not unusual to have pretty significant adhesions in the mediastinum, which could make emergent reopening in the ICU a real potential for trouble. But a central cannulation, obviously the goal is to have optimal venous and ventricular decompression. And the major issue with post-cardiotomy central ECMO is the risk of bleeding. I wanted to just in the last few slides here talk about some couple of other scenarios where central cannulation versus peripheral cannulation might be the choice. And I know there's an entire session dedicated to ECMO and sepsis, but central cannulation is really the choice of cannulation when you're treating a child with refractory sepsis. It's really the strategy that allows you to provide sort of supranormal flows, so greater than 150 cc's or 200 cc's per kilo per minute. There are, with some of our newer pumps and newer cannulas and some innovative cannulation strategies, I suppose one could try to obtain these types of flows with peripheral cannulation, but I would say that the experience with central cannulation has really been the one that's been reported to have the best outcomes. But the adoption of it has been mixed or slow, I think, in many centers. And I think it's less about the outcomes for these patients, but certainly in our center, we've seen this is mostly a logistical one, where central cannulation needs to be performed by cardiac surgical teams in the operating room, whereas these patients are often in the medical or pediatric ICU, and access to this therapy is one that often takes some time to coordinate. And if you're going to deploy this, it needs to be done relatively early in patients. I have been involved in these cases, and again, these are not straightforward central ECMO cannulations, and there is in fact an increased risk of bleeding complications in this subset of patients. One other specific case I wanted to describe was the use of central VA cannulation after lung transplant. I think in majority of the centers that do pediatric lung transplants, most of the indications for transplant are now cardiac, and so ventricular dysfunction is not uncommon. And so we have an innovative way of supporting these patients to make sure we have adequate PA blood flow. So we use both a PA arterial and aortic arterial cannula wide together so that we can give continuous flow into the lungs and make sure there's good perfusion of the lungs. So in summary, decision-making around optimal cannulation strategy for VA ECMO in children should always be driven by patient-specific factors, but that support strategy needs to be followed with a pragmatic, vigilant, continuous re-evaluation. The multidisciplinary teams of intensivists, ECMO specialists, and surgeons should really be collaborative so that you can achieve optimal support, change course, change direction with your cannulation strategy depending on what the patient needs for best outcome. Thank you.
Thank you, Giles, and thank you very much to the conference organizers. If I haven't misread the program, what's going to happen now is that three of us are going to make a case for how best to select mechanical circulatory support in children with cardiogenic shock. So thank you to the conference organizers for giving me the easy one, trying to sell ECMO at an ECMO conference. So I have one disclosure, which is I'm on the board of ELSO. So in a spirit of antagonism, confrontation, and debate, I'm going to begin by destroying my other co-speakers' arguments. Now, those of you who look after children on ventricular assist devices, obviously there is an important role with the use of VAD in cardiogenic shock. The question becomes, of course, at what point do you deploy it? So I'm going to start by talking briefly about what VAD can do, and we've seen images like this before. Obviously, on the left, you can see a critically ill child in all sorts of trouble. You put in a Berlin heart, and very rapidly, the child's extubated and doing fantastic. You just saved his life, and now he can walk around or go home. So, obviously, it's not quite as simple as that, because VADs have significant limitations. First of all, they may not necessarily support both ventricles, And the need to support both ventricles and biventricular circulation, we all know, is associated with worse outcomes. Clearly, VADs don't support the lungs. And before you all rush to say, oh, but I can put an oxygenator in my RVAD, yes, you can, but I don't think that oxy-VAD is the same as VAD. And there are certain limitations to the oxy-VAD strategy, particularly in the setting of sepsis. We heard our previous speaker discuss the issue about septic shock and high flows, and a VAD may not be able to achieve those high flows because of design. But I think the main limitation to most of us, and particularly in this day and age where cost is being looked at and re-looked at, is that VADs are incredibly expensive. Now, this paper is a few years old. I think it was published in 2015, and it was looking at patients in the United States between 2000 and 2010. And you can just see from the figures there, the median cost for hospital admission in which a child received an LVAD was $1.5 million. Now, that's not trivial to anybody anywhere. And if you look at the interquartile range, 2.2 million. So that means 25% of those patients, their hospital admission costs were above 2.2 million. So that's extravagant by anybody's yardstick, I think. What about the Impella? Well, this is the current family of Impellas, and yes, they're very, very useful percutaneous left ventricular assist devices and now percutaneous right ventricular assist devices. One thing that's not included here is the BTR, which is just becoming available in the United States, and that'll be interesting to see whether it finds a niche in older adolescents. But the problem with the Impella, of course, it's not designed for children, it's designed for adults. And a lot of these patients that we have to look after are small infants. So the Impella is just off the table. It's too big. It's not as expensive as a durable VAD, but it's considerably more expensive as a device than conventional ECMO. And I think, please correct me if I'm wrong, there's really minimal experience with using the Impella in children. I think even if you go to the biggest pediatric cardiac programs in North America, you're not going to find people who are using the Impella on a daily basis. Whereas if you go to adult programs, they are using it on a daily basis. So I don't think the experience is there either. So the Impella is trying to potentially squeeze, a square peg through a round hole. So what about ECMO? Well, this is an adult study, as it happens, but I think it applies equally well to children. This was a study comparing the use of ECMO as a bridge to transplantation or to VAD and then transplantation. And you can see actually the outcomes are the same. And I think there is a signal in the literature that outcomes are better if you're transplanting from VAD than ECMO. I'm not the person to talk about this, but I know in the United States there's been a change in the organ allocation system, I think in 2018, and that has changed device selection considerably because you're in a position to get transplanted faster from ECMO than you are from a VAD. But at least looking at these data in adults, outcomes can be the same. Now, in a brazen attempt to butter up my chair, I'll just quote his research. And I illustrate this, it's a case report, but it's a very important one because it illustrates an important principle. Normally, when we think about ECMO as a bridge to a bridge or as a bridge to transplantation, we may have 10 to 14 days before you need to commit yourself at most. But it's important to recognize that some patients, it's technically impossible to put a VAD in some children with certain forms of congenital heart disease. And if you modify your ECMO circuit appropriately, you can bridge them with extremely long ECMO runs. We know that the longest pulmonary ECMO run in the world ever was 604 days. And that was a 7-year-old girl with smoke inhalation in Baltimore who is now home and well. This, to my knowledge, is the longest VA ECMO run in the world. So they did 394 days VA ECMO and bridge to transplantation. Now, again, this is not normal or common, but it illustrates a principle, which is that you can bridge children to transplantation with prolonged ECMO from an experienced team. The 6th edition of the Red Book is a marvelous piece of work, and thanks to Giles for editing it. So this is a section of chapter 44, which is talking about mechanical circulatory support, and this is a section written by Ravi Thiagarajan, who's the chief of cardiac critical care here in Boston. And you can see that this algorithm looks at children in cardiogenic shock and where you go depends on whether the child's had a cardiac arrest and the degree of respiratory failure. And I'd like to thank my previous speaker for using in his case vignette, you saw, 14-year-old presents in cardiogenic shock to Boston Children's. Did they put an Impella in? No. Did they put in a durable VAD? No. They started with veno-arterial ECMO, which is what I think people should do. And again, in another brazen attempt to butter up my chair, Peter wrote chapter 20, which is the chapter in the Red Book which discusses bridging children with cardiac failure to other forms of treatment. And this is a nice algorithm which takes people step by step through the considerations you should use when trying to bridge. So in conclusion, in my view, veno-arterial ECMO should be the default modality of choice in children presenting with cardiogenic shock. Why? Because compared to other strategies, it's inexpensive. It supports both ventricles and the lungs, and it gives you a chance to at least bridge the child to decision, if not recovery, whilst you consider more elaborate therapies. Thank you very much.
Good morning, everyone. Looks like we're going to have a bit of a battle here, so I'm going to try to do my best. So thank you for inviting me, and I would love to share with you guys some of the pediatric experience institutionally, and as well as finally able to report some multi-institutional experience with the device. So I don't have any relevant financial relationships to disclose, and temporary mechanical support is important. It helps us recover these patients who have refractory cardiogenic shock, do not respond to our medical therapies, and they need something extra. And it can serve as a bridge to recovery, decision, durable support, and as Grant nicely highlighted, even a transplantation in some settings. So VA continues to remain a main sort of therapy and the most widely used method of support due to mainly its costs, ease of deployment, rapidity of cannulation, ability to provide biventricular and respiratory support for our patients. And the outcomes are a little bit challenged. I think they're confounded by mixing a population that's a congenital cardiac surgery population, post-bypass, et cetera, and not really well delineating this typically presenting a myocarditis patient population, et cetera. So the outcomes have to be interpreted carefully, and we have to do a deep dive into the literature. One of my colleagues, Javi Lassa, has recently published a PC4 experience with patients with cardiogenic shock presenting to our intensive care units, and he has shown that 12% of these patients will require some form of mechanical circulatory support. 12% of them required ECMO, 4% went on to a VAD, and mortality rate was around 40%, so 60% survival, and that seems to be matching what ELSO database is reporting for our cardiac populations in neonatal and pediatric population being somewhere close to a 60%. So I think we're sort of starting to get the signal. I think there is more digging that's needed in order to get us more accurate data. The drawbacks of peripheral ECMO include a potential impairment of LV injection and increased afterload. That leads to increase in LV and diastolic volumes, as you can see on the figure to the right. It leads to an increase in left atrial pressures, resulting in pulmonary edema and hemorrhage if not treated appropriately. It delays ventricular recovery. Adults have shown quite a few publications recently on this, and it's a significant issue in the setting of myocardial infarction. And it can lead to a thrombotic event if not appropriately addressed, as Francis nicely delineated in his presentation, that if not treated appropriately, these can lead to significant thrombi in the ventricles and devastating events. We, over the years, have developed multiple modalities to deal with this, and I think we've done a better job than our adults colleagues have done with ability to offload that left ventricle. And you can approach it in many ways. You can adjust ECMO flows if allowed. You can provide some additional inotropic support to achieve some ejection and reduce dose and diastolic volumes. You can provide, obviously, most importantly, afterload reduction. But we have introduced atrial from our congenital experience. We have, obviously, talked about already LA and left ventricular events as additional modalities. But there is obviously a new agents that are, or new devices that are coming into the market that I think we should explore in that setting and find the right population for them. The physiological benefits of LV unloading are quite unquestionable these days with all the adult data that is coming out, and it leads to reduced left ventricular pressures, reduced pulmonary venous congestions, wall tension of the myocardium and increase, if not appropriately decompressed, it leads to a higher myocardial oxygen demand. But if you decompress appropriately, you can increase actually myocardial oxygen demand and coronary perfusion pressure. The figure to the right shows you a little bit sort of what happens when a patient is placed on ECMO from cardiogenic shock. You have significant increase in LVEDP, significant increase in afterload. ASD does a good job of offloading that ventricle to some degree. The challenge is it doesn't do a full job, so it doesn't allow you to come back to a low end diastolic pressures, but some of the direct LV decompression strategies will enable you to decrease this left ventricular diastolic pressures and also subsequently reduce the afterload. The data in adults is quite extensive and actually suggestive of huge benefits of LV decompression, and we're starting to see some more publications in pediatric. And Zampi et al. Has very nicely, in a multidisciplinary fashion, delineated a benefit of early left ventricular decompression. They define that period as 18 hours, and they have shown that if you do it well, you can reduce the duration of ECMO support, you can reduce the duration of intubation for these patients. What I think is essential to understand is that a lot of these publications lose focus on the actual outcomes that are consequences of LV decompression and often focus on patient survival, which I don't think is a good choice of an outcome for this population. So what about Impella? So Impella is a percutaneous axial VAD that can be deployed directly into the left ventricle. It's implanted through a large artery. It could be either femoral or with the help of our surgical colleagues, often done through a subclavian or axillary approach. And its advantage is it comes numerous in various sizes as well as degree of support. And it's found its place in LV unloading on ECMO support, LV support for cardiogenic shock, and bridge to decision or transplant, now more commonly deployed in adult population. And it's very frequently used in the high-risk PCI procedures in the cath lab. It comes in various sizes that each one matches a certain degree of flow and the size of the device. The Impella 5.5 can deliver up to 6.2 liters of flow, so almost matching what our durable VADs are doing in some of our kids. And the smallest device is Impella 2.5, which can deliver only 2.5 liters of flow. There obviously vary in deployment techniques and who do you need at the bedside in order to get the device into your patient. I'm going to share with you guys a little bit of data. Unfortunately, there is a lack of pediatric experience with ECMO and Impella out there in our publications. So I'm going to share a little bit of TCH experience and hopefully help you sort of delineate the population size and sort of outcomes there. We've used 10 devices in 10 subjects thus far in the setting of VA ECMO for purely a decompression of the left heart. As you can see, the patient population is bigger, so 13-year-old median age of patients, and there are 53 kilos was the median weight of those patients. So you can see a much larger population, certainly not allowing us to address the infants, the little babies that won't be able to be supported with this device due to their vessel size. 60% of our patients achieved recovery of LV functions. 2 had the device explanted in the setting of severe hemolysis, and 1 patient had limb ischemia, and we had an 80% survival to the hospital discharge. The predominant device here used was Impella CP, and we've used Impella 2.5 in 3 cases, and those were the smaller patients. So pretty satisfactory survival of these patients to discharge from hospital. We did have 2 patients that died after explantation, after coming off of ECMO, mainly to succumbing to their chronic illness in the hospital. And outcomes are quite favorable. I'm happy to report we don't have any neurological injury on this device, but the predominant problem is hemolysis. You have 2 devices that are working subsequently. Each one of them is causing some degree of hemolysis, and the hemolysis here was actually defined per PDMAX criteria, so I'll challenge that a little bit. Median length of support on these combined support therapies was 4.5 days, with an ECMO support of 5.4 days. So factors to consider when choosing an Impella to unload the ventricle in the setting of peripheral VA ECMO. First of all, you need to understand whether that ventricle needs to be unloaded. Not every patient needs an unloading strategy. You need to optimize their hemodynamics, you need to optimize your therapies, and then decide whether that ventricle is still struggling and needs some form of decompression. Patient size is a challenge with this device. As I've delineated, probably any patients more than 12 years of age should be fairly safe to use in this strategy. Available vascular access is a challenge. You want to make sure you have enough of access available. Often these patients will be cannulated through a femoral route. So you will be limited to only one extremity. You want to make sure that extremity does not have any thrombi, et cetera, so you don't assassinate the limb. And then cardiac and ventricular anatomy, specifically in our cardiac in pediatric population, because we deal with congenital heart disease, we deal with previous surgeries, et cetera, presence of various valves in these patients. So we do have to be careful when choosing the right population. I'm going to shed a little bit of light on the Impella in the setting of just cardiogenic shock. I've been asked to do that off of ECMO as well, so there is limited experience. Vivian Dimas and Deval Parekh from our institution have published on this, showed pretty favorable survival in this population. But what's impressive, we've been able to do a tremendous amount of work with Action Collaborative. We've shown that there is significant increase in the use of this device over the past few years among many institutions, so we're gaining more experience. And 15 pediatric centers contributed to this data. We showed that yes, patients are bigger that you can utilize this device in. They are sicker with Intermax when stage 1 and 2, so close to what our ECMO patients would need. 50% of them were intubated. Predominant cause need for support is the transplant graft dysfunction and the myocarditis. Those are the predominant sort of disease processes, and the device was primarily utilized in the setting of bridge to recovery and the bridge to transplant. Adverse event profile, also quite favorable. We did not, amongst all these 15 centers and 47 patients, we did not experience any neurological events. Majority of these patients had issues with hemolysis, and we're learning a lot about that. So support outcomes, positive outcomes, which was achieved at 85% of these patients, 77 survived to explant of the device, and 8% were alive on the device at the time of assessment. So quite favorable. Conclusions, patient size, once again, remains a limiting factor for this device. Diseases outside of cardiogenic spectrum should be considered. You'll be approached to support a patient with sepsis. That's not the right patient to do. They have high output states. You won't be able to achieve much higher output with an Impella device. Put them on central ECMO and call it a day. The device support should be matched to actual cardiac output needs. If the patient requires 5 liters of cardiac output, you cannot put a 2.5 device in them and expect for them to recover. So you do have to match their cardiac output needs with what the device can actually provide for you. And Impella provides adequate LV unloading, but it fails to take care of the venous congestion, fails to take care of the suboptimal RV. Often our RVs fail because of the high left-sided pressures, high pulmonary vascular resistance, and struggling RV. If you take care of it very well, that RV will immediately improve and you won't be struggling with it. But if there is an intrinsic RV failure, such as coronary ischemia or some kind of intrinsic RV dysfunction, those patients will struggle. We are getting some signals in our database now that the dilated population might be more challenging to support with this device. So keep that in mind. How do we move forward? Pita and I talked about it so many times during this conference. We need a new definition of cardiogenic shock. We need a more robust definition of cardiogenic shock. Otherwise, I don't think we can move ahead with mechanical support in this setting of cardiogenic shock if we don't speak the same language. We need to speak the same language when it comes to discussing indications and complications, and I think I saw some of FDA folks that gave talks a couple of days ago. They completely agree with us, so let's get together and figure out how we're going to talk the same language here. And then update our clinical databases. They capture ECMO, they capture some VADs, but they fail to capture the new technologies that are coming through. So in order to provide better therapies to our patients, we need to have that data available for us to analyze. All right, thanks so much.
Thank you. It's a pleasure to be here. Making the case for VAD at an ECMO conference is different from making the case at a VAD conference, so I realize it's a challenge. I'm going to share some of Angie's data. She was sorry that she couldn't be here. Let's see. So I have no direct financial conflicts here. So I'd like to review the potential advantages of managing a patient with cardiogenic shock with a VAD, to review some of the clinical experience of this, and then to talk about some scenarios where that may make the most sense. I think you can already sense my argument is not that VAD should be primary therapy, but there's probably some segment where it's appropriate. So quick case, this is a 4-year-old, 13-kilo, previously healthy boy who presents to an ED with a 2-month history of fatigue and decreased PO intake, and a 1-day history of labored breathing and vomiting. He's followed in the cardiomyopathy clinic for an MYHA7 mutation and has a maternal grandmother who had a heart transplant. The exam is notable for being cold and wet. He's got a gallop, labored respirations with a liver that's 4 centimeters below the margin. It's a heart rate of 160 with short runs of non-sustained VT. The BNP is greater than 30,000. That should probably be an NT-proBNP. The lactate's 4.5. BN and creatinine are a little bit elevated, and the ALT is as well. The echo shows a thin and dilated LV, 62 millimeters, so a Z-score that's pretty high. Moderate MR, RV dysfunction with mild TR. Now, about after 18 hours in the ICU, the lactate is still, came down initially to 2 and then is inching it back up to 4. It has a mixed venous SAT of 39%, CVP is 12, and this is despite intubation, milridone, diuretics, epinephrine, sedation, and paralysis. This is the echo, and there's no video here, but if there were, it wouldn't move very much anyway. And you can see the heart size here is pretty large. So the question is, what is the next best step in the management of this patient? It's a little bit like the USMLE question. Is it VA ECMO? Is it MPELA, VAD, or possibly VA ECMO to VAD? So I think it's helpful to think about the context here, and this really is a discussion about heart failure as the theme for the session. So I think one of the things that VAD can do, and we've seen this do this very well, is provide effective circulatory support. Of course, we like to think both about forward perfusion, so systemic perfusion, but also adequate decompression of the systemic venous system, which we know can also cause problems with end organ dysfunction, both renal and hepatic. There's also direct LV unloading, and I think Sebastian showed the nice pressure volume loops, which scare most people, but if you just knew one thing, it's the smaller the pressure volume loop means the less stroke work or energy for the heart. And this does this very effectively. So it's dealing with the primary problem directly rather than indirectly. There's effective coronary perfusion in this scenario. There's you avoid essentially vascular complications or problems cannulating the neck, and sometimes ultimately the vessels have to be ligated. You also avoid secondary procedures like septostomy, and of course all of us have seen a big ECMO circuit go off to the cath lab, and it's quite a production to do that. You also have the risk of coagulopathy that can come up on ECMO before you transition to a VAD. You have repeated episodes of inflammation just because of the huge total surface area that the child is exposed to in terms of artificial area. And then I think we oftentimes think of VADs as only being for bridge to transplant, but sometimes they're being used for bridge to recovery. And this is really where Cincinnati has probably done some of the most interesting work. I think one of the most critical things is that timing is everything, and this has been emphasized in a number of sessions here. But you really need to be ready to go to the OR when you have a patient like this. This is not the sort of scenario where at 6 o'clock at night you can say, all right, I think we'll schedule the VAD for the morning, because it won't work out very well. You have to be really ready to go, make the patient NPO, go downstairs and put the VAD in right away. Cannulation can be LV or LA. In this scenario, again, Cincinnati's done some work with LA cannulations for short-term circulatory support. And in some cases, could even be done off bypass. So this is the group in Cincinnati. I probably should have put Chet's picture up there as well. These look more like bypass cannulas to me, but this is kind of the approach that they've taken, and you can see that's an example of biventricular support where they were managing shock. So I think we're all familiar with Intermax profiles and how in VADs, patients with Intermax profile 1, which is really the blue line there, really have the worst survival. So you can really see it separates. There's another way of looking at this curve, is that 20% of patients do pretty poorly, and that's the group that actually dies relatively early. But you could also argue that some subsets of cardiogenic shock patients do pretty well on VAD support. And if you look beyond the alpha phase of the curve to the beta phase, you can see that the hazard there actually is relatively similar to other less sick forms. So there may actually be some heterogeneity within that cardiogenic shock group where some can benefit. This is Cincinnati's experience with, I think, 19 patients that they've done with short-term surgical VADs for support. And you can see the median age there is 10 years, 3 days to 22 days of support. Most of it was with Rotaflow, some of it was Rotaflow, and most of it was with the CentroMag system. And their outcomes actually are relatively good. 84% of patients had a good outcome, and this includes 37% who went on to a durable VAD. So this is generally for a bridge to transplant group. So I just want to talk about some scenarios or things to consider for primary VAD. I think it's probably generally preferable where the form of MCS is really likely to lead to bridge to transplant. And I think this addresses some of the issues of excessive use of VADs, which is an expensive therapy for short-term support. It really needs to be early, not late shock. This is really where the kidneys, liver, and lung, that injury is really reversible with VAD support alone. Yes, one can add in an oxygenator, and it's true that that sort of oxygenator support is not as effective as primary VA ECMO, but it can be done if the patient needs it for 24, 48 hours. It's really important here to have access to a surgeon and OR team on a moment's notice for the reasons we talked about before. And then there's always the issue of RV function, I think that Sebastian raised. And this is one of the hardest things to predict in VAD therapy. I think it's probably that we need to start not only looking at the ventricular function, but also the ventricular load and also the environment or neighborhood that it's in. So if the kidneys, you could have the same kind of moderate to severe RV dysfunction, and if the kidneys and liver are really pretty good, then it's probably safe to get away with an LVAD alone. If this has been long-standing fibrotic liver, other things, that same degree of RV dysfunction, you're probably wise to go with biventricular support. So this is really something that needs to be considered. And then one has to really prepare for the difficult scenario where if you do put a VAD in and the patient isn't a candidate for a transplant, that there is plans for what to do in that scenario. And that can be one of the most difficult because oftentimes these patients are not asleep, they're actually awake. So while many patients are not eligible, direct VAD implant can be effective in the right patient at the right time. I just want to mention one last thing. People familiar with the term gloaming? This is about trying to get timing right. Gloaming is the time of the day where the sun has gone down, but there's still light in the sky. And I oftentimes think that the ideal moment in time to do a VAD is where things are going to turn dark quickly, but you still have some time to reverse it. Not that you can reverse the gloaming, but it's a nice time of day, but these sailboats really need to get back into harbor because the sun has gone down and it's going to get dark pretty quick. So there is time to act during the gloaming, but timing really is everything with VAD implant. So our patient actually did pretty well, got a CentroMag and a Berlin, got extubated on post-op day 3. Probably another advantage is possibly early is shortening the period of sedation, transferred out to the floor, and is doing well. Could we have done ECMO as a bridge to the VAD in that patient? Absolutely. We probably could have gone either way. There's almost equipoise, but I just wanted to highlight what some of the advantages are. This is our VAD team at Stanford. Thank you very much.
So if you'd like to ask any of our panel members questions regarding the session this morning, we'd love to hear. I'm sure Giles has got one to start with.
I'm going to kick us off. All of the panel members have presented a slightly different twist on how to do it, and I suspect that where we come from, whether a surgeon or an intensivist or a cardiologist, has a big impact on how we work. What's the true way of doing it? What's the one way that if you had all of the technology, you had the impeller, you had the surgeon available 24/7, you had infinite Berlin cannulae in the cupboard. What's the best way? And I'm going to go first.
I think one of the things I didn't mention, Sebastian mentioned this, but we do still have kind of a critical lack of ideal devices for children. There's no Impella 0.8 or 1.0 or 1.2. So for the patient that I selected, there just aren't devices that are really suitable for that population. So a lot of this is about what's the landscape of devices. I think the most critical thing really is identifying the patients early so that you can intervene before there is irreversible end organ dysfunction. Obviously, if the lungs need to be supported, then ECMO becomes the best strategy. If that's not the case, and you think that primarily recovering the LV can do it, then I think a VAD approach seems reasonable. I suspect we all think about it the same or in a similar way, even if our institutional approaches are slightly different.
Yeah, I mean, the degree of certainty in my voice and presentation was purely for the purposes of debate. Obviously, the device landscape is one issue. The state of the patient at referral is another. And Chris's example of a child who's presenting in progressively decompensated shock, I think, is a nice illustration of when to use VAD well. And if you have the time and resources in a child who's clearly deteriorating despite conservative therapy, I would agree completely. I would take the child to the OT and put a VAD in. But obviously we don't always control our referral base, and you may have a child who presents either, approaching cardiac arrest or with very, very advanced multi-organ failure, and I don't think that child would be best served by a VAD. I think resting the child on ECMO would be a better strategy as a bridge to decision.
I guess my only comment as a surgeon is, and many of you may be shocked to hear this, that I think putting a VAD and doing a sternotomy in a child, if you think you can recover them with peripheral ECMO, I think that, in my mind, that's sometimes a hard trade-off. So I think for me, it always comes down to what I think the etiology of their heart failure is and what the duration of support is likely to be. And that's at best, that's always the best guess. But that's, in my mind, an important factor.
It's interesting because I think it's a combination of a couple of factors. Obviously, age is important in our population, right? You won't address an infant the same as you would address an older patient. I think the spectrum of a cardiogenic shock is sort of poorly defined by us as intensivists and in the units. And I think we see various degrees of it. Obviously, you won't be fooling around with an Impella and a kid who just gets rolled out of the ER with ventricular arrhythmias and no perfusion. Like, there is no reason for that patient to be approached probably with anything different than ECMO. You just have to have appreciation of what needs to happen afterwards and where the patient is going. And to the same degree of a patient who's slowly deteriorating in your unit, no one's going to jump in and put them on ECMO, but you have these opportunities to think about durable VAD strategies to enable this patient to actually achieve rehabilitation, decrease sedation needs, and things like that that would be beneficial in the longer term for this patient. So it's quite a complex problem, and I think it should start with that definition of a spectrum, which adults have done a great job. I mean, we've seen this at presentations numerous times during this meeting, is utilizing things like the SCAI scores for cardiogenic shock and hemodynamic parameters to define it better.
Thank you very much. The speaker recognizes Professor LaRusso.
Yeah, LaRusso, Maastricht, the Netherlands. I really enjoyed your presentation, and what came out really clearly is that it's not so simple, and you have to really examine carefully and in detail each patient, because choosing the right option, that is what is now possible, to have more devices, more options, more opportunities, but we really have to be careful. Like left ventricular venting, I saw so many disasters because you put a cannula you want to unload completely, and then you have no ejection, you have an aortic valve completely closed. So we have also to remember and remind that sometimes we can also go towards an overdoing. But my question is, I think that we should really understand to apply and select carefully our patients. So what is your opinion regarding shock team, for instance, or maybe a super specialization, but I think this could be the answer. What is your opinion about having this kind of approach, because each patient can have a different need?
I'm sorry, Dr. LaRusso, can you just repeat the question, please?
Yeah, I mean, what is your opinion about the use or the realization of the need of a shock team for the decision or decision-making in all these kind of cases? Because you show clearly that each case is different. And therefore, maybe we need really to go too deep.
Thank you. Look, I was distracted from your question by getting a text from somebody in the audience saying, great point. That's exactly what we need in pediatrics. And I think that what you're suggesting is something that in a large volume center should easily be achievable, and in a small volume center is potentially even more important. A group of people.
Remote consultation, maybe?
Yeah, absolutely. No, I completely agree with you, and I think the issue for many centers will be identifying the right people with the right experience to be available at the right time, which is it's consistent with everything that we've talked about this morning. Thank you for making the point. There are so many things that pediatric practice does well that can be translated into adult practice, and so many things that the adult programs have got well established that we need to consider for pediatric practice as well. And I think the shock team is a classic example of that. So thank you so much for making the point.
Thank you very much.
I've got the microphone,
He's
and
got one as well.
I'm going to ask Nicole Gillette to ask the last question. Nicole, thank you so much for joining us from the FDA.
Oh, yeah. So assuming that all the devices are on label for pediatric cardiogenic shock, do you think that the phenotypes of cardiogenic shock are going to play a role into what device is selected, if it's Impella, ECMO, or a VAD? And can you kind of talk about that?
Yes. Yeah, I mean, I think that sort of builds on everything that's just been said, is that I think once much like in the adult world, once you have this potpourri of devices, once you can just pull stuff off the shelf, regardless of etiology or size of patient, and you have devices available to you, you can really tailor the specific device to the duration of support and the type of support the patient needs. So I think that the answer would be yes.
Yeah, I would agree as well. We kind of know that pediatric device development is a huge problem. We just don't have the tools that the adult world does. 2/3 of the patients are going to be less than 12. I think Sebastian said it's maybe the lower age for the Impella. It just means that there's a huge area where there's unmet need, but trying to draw devices into this space and also get data for them is pretty crucial.
Yeah, I think the key thing in my mind is the size of the patient. The smaller the child, the harder it is to support them, not just through a lack of devices, but because of an increase in the complication rate, and particularly the thrombotic complications. So, yeah, I think that's where it's most important to focus on. Thanks.
Yeah, actually, I think, FDA is doing a great job at getting these devices on the market. I think where FDA could help more is actually challenge these companies to build something for kids, because that's not very profitable for them. And I think we're suffering from this on numerous ends, whether it comes to hemodynamic monitoring or a ventricular assist device or acute therapies. So I think this is where the challenge could be placed on these companies to do something for kids.
Completely agree, but we need the help of academia as well as industry. It's a whole collaborative to get devices on label for peds.
Thank you so much for
I
making that
don't think
point.
you can finish better than that. I think that's exactly what the conclusion is.
I was going to say exactly the same thing. If I could have written the conclusion for this talk and this session, it would have been exactly as mentioned by Nicole Gillette from the FDA. We've got a lot of work still to do, but my goodness, we've got the right team to do it. So thank you so much for your time this morning. Please approach the speakers, but give them your thanks. Thank you.